So another assessment for the ankle, which we can also use as a very good exercise as well, but it's nice to use it as an assessment if you have got an ankle pain patient in as well, is the foot clocks. Now you can go all directions with these. We're just going to focus on sagittal plane today, but you can do frontal plane, you can do transverse plane, and obviously frontal plane and transverse plane, you're going to drive a lot more inversion, eversion as well. But for today, we're just going to focus on the sagittal plane. Now, if you're doing this as an assessment, you can put a meter stick on the floor, and obviously all you're going to do is nice and easy. I'll get you to do it, Sarah. So if you're going to keep your weight on the left leg, I just want you to reach forwards with the right leg as far as you can, but don't put any weight on the right leg. You're just going to reach and point the toes. That's it, and then back again. Good, same again. Just hold it at the end. Nice, and back. So I want to see that they've got control with this. So same again, let's do a few more. Nice, good, and back, and again. Nice, good, and relax. And just do the same on the right side. So reach the left, and back, nice, good. And again, just eyeballing that, Sarah, looks pretty even there. But again, obviously, if you've got an ankle pain patient, you can get your meter stick out and you can compare the distance that they can reach on left and right. Now, this is obviously a very similar movement in the standing ankle as our knee to wall test in terms of getting dorsiflexion, but it's a completely different ball game because it's dynamic now. So now we're looking at dynamic stability between the ankle, knee, and hip as we're reaching the opposite leg. So if you go forwards again, Sarah, just keep the weight on this leg and reach the right one forwards. So as Sarah reaches forwards, there's a lot that needs to happen. She needs a good co-contraction at the knee. So this is where we go back to module 2 now with our posterior knee stability. You can come back again. Nice. So she needs a good co-contraction at the knee, and she needs to be able to decelerate quickly. So she needs a fairly decent co-contraction here. So same again. Going forwards. And you can see for Sarah, to be honest, I'd like a bit more of a stop, so her knee comes really far forward before she stops. Now, as an assessment, this isn't too bad, but as an exercise, if I was doing my lower limb return to play, I definitely have got some other progressions that I'll be doing first before kind of taking it to this level. Just do the same again. Obviously, ankle now, we've got to shift the weight forwards to the forefoot, so we're actively plantarflexing, but passively dorsiflexing. I hope that makes sense. So even though you're going into the dorsiflexion because of the movement, obviously to stabilize yourself, you need to plantarflex into the floor. So we need a really good intent and contraction through the gastroc and then we need that to co-contract well with the hamstring, quad, and glute to keep the leg stable. Okay, so again, similar thing here. I'm looking for what's bringing, if they're getting any symptoms, what's bringing on pain, are they getting a pinch at the front, are they feeling tightness at the back, and just can they do the movement, can they decelerate? What you'll see a lot of the time with people who've got ankle problems is they just don't want to move. So they'll try and keep the knee still, or they'll keep stepping forwards with that leg, and they're not happy to control or decelerate the motion through the affected leg. Okay, so quick recap, definitely want them to pause. So you'll see a lot of people that fly through this and just do that, but you definitely want this to do the movement and pause and then come back. So, and if you're doing this as an exercise, like end stage progressions, I want them to bridge the gap as quickly as possible, but still pause. So it's a bridge, pause, and then come back. Bridge, pause, and then come back. The other things that we need is we need a good posterior knee stability. What that basically means is we need a good co-contraction between the gastroc, hamstring, quad, and glute to stop us basically and slow us down. And then obviously we just need that good dynamic stability.
Yeah.
Make sense?
I can sort of feel my heel coming off the floor when I'm doing it at the bottom as well.
Yeah, and for me, you haven't got a good enough co-contraction at your knee at the moment because we haven't gone through the full lower limb progressions. Does that make sense? So again, what Sarah's saying there is that she feels the heel coming off the floor. Now, if I've got a really solid co-contraction at my knee should stop before my heel comes off the floor. Does that make sense?
Yeah,
so, because we know you've got really good dorsiflexion, so that could be a dorsiflexion issue, but I've ruled that out with my knee to wall test. Okay, so that's actually a really, really good point. And this is where your whole assessment and the whole clinical picture comes into play. So obviously, if someone's got restricted dorsiflexion, the heel's going to come off. But we know you've got really good dorsiflexion because we just checked it. So when we're bringing Sarah into dynamic movements, she's still feeling the heel coming off. So what that's telling me is that the weight's coming too far forwards, her knee's coming too far forwards, so she's coming too far forwards onto the toes, and that's causing the heel to come off. Whereas if that hamstring gastroc stops you sooner, then we'll get it. So what I want you to do now is do the same thing again, but really squash into the floor, really squash and back. Okay, cool. So just a little bit less movement. So don't worry about this leg, don't worry about that knee, just think of this foot. That's it. Good, perfect, nice. Same again, squash harder. Okay, good. Squash harder. Okay, cool. So now we're getting quite a lot of knee bend here, so I still don't want that much knee bend. So what I want you to do now is I want much of a less bend in the knee, so just about 10 degrees, that's it, and back. That's it, same again, still pause, and then back. Nice, good. Now do a few more of those. Good. Okay, and again, so She's getting a better movement there, the heel staying down, but this is quite difficult. So like this is too far, it's too high a progression at the moment. So what we've got here is we've got a posterior knee issue. Does that make sense?
Yeah.
So your knee wants to come really far forwards because you want to use your quad. So your quad dominant, you really want to eccentrically load through your quad to slow this movement down. But what I probably want for you now is more hamstring calf. Now, if I wanted quad for whatever reason, that's fine. But usually for running, walking and stuff, I want a better co-contraction between the hamstring gastroc. I don't want that much knee flexion. I just need 10, 15 degrees. So for you, we need to load those progressions first. So we're going back to our co-contractions now and loading from there. And this will be a progression. And the difference now is speed. So now because we're challenging that speed, because I know you can do the co-contraction stuff fine, but because we've upped the speed quite quickly now, whereas the co-contraction is probably more load, but once you get there, you're fine. This is adding a lot of speed into it now, and that's a really important variable to play around with because speed completely changes the body's reactions as well. It's really, really good. So again, that's a really nice one to combine with the knee to wall because we know Sarah hasn't got a dorsiflexion issue, but we can see there's definitely the heel coming off as she's going forward. So now I'm thinking that's going to be a co-contraction issue. Obviously, we go back to the bed now and confirm that. So that's it for module 9. So I suppose module 9 is just kind of consolidating module 2 really, the lower limb stuff, but now applying that to some specific cases. So obviously we did the ankle assessment this week. Also we've got the pathological knee assessment. Obviously it's important not to forget that because obviously if there is pathology there, we need to respect that and be able to treat it. And then being able to apply the system to things like, you know, Achilles problems, shin splints, etc. How have you been getting on so far, Sarah, do you think?
Good, yeah, I think when you kind of go through this at uni, they overcomplicate it, and now that we've actually got something to relay it back to by doing module 2 anyway, it kind of makes a little bit more sense.
No, I think that's right. I think when you've seen a few patients as well, and then you would watch module 9 again, it kind of helps to kind of consolidate the learning a little bit because I think it's like any course, it's easy to get the theory and kind of understand it, but then when you get in with a patient and trying to apply that practically, sometimes obviously your thinking get a little bit muddled, and when you have to think on the spot, that's when it's challenging. I think being able to apply it to specific cases and then being able to kind of translate that into what you're seeing in the clinic, that's a big help, I think.
Yeah,
definitely.
I think as well you get a lot of people that say, oh, how do you treat this and how do you treat that and what can I do for certain things. You've got to kind of remember that you've got to go back to your full assessment as well and link it back to that. You can't just give them a simple answer and say that that's what you've got to do, kind of thing. Yeah,
I think that's a good point, and I think the system's always there, so the progressions are always going to be very similar. Obviously, depending on what the person wants to get back towards. But at the end of the day, if we have 10 people that want to get back running, our progressions are probably going to be similar. What's really important is the stuff that happens before then. So that's our assessment. So being able to link our assessment with the person's story, make sense of the assessment findings based on their history, and then getting them to the point that we're able to take them through those progressions. And I think the roadblocks that you hit are going to be very different with different people. So you might be doing very similar exercises, but one person, struggles with it for this reason, another person struggles for that reason, and that's when we go back to our assessment. And that's where the things like the knee to wall test and the dynamic ankle assessment, that's where they become really powerful then, because we can troubleshoot those problems, address them on the bed, and then when we get back up and do the exercise again, it can be completely different. And I think that's the power with the hands-on on the mentorship, is we can make really quick changes that then allow us to get to the next stage of rehab very quickly. Whereas we could do maybe spending a few weeks on different exercises trying to build up to that. But if we can do our hands-on and create short-term changes that allow us to be able to do the higher level of rehab quicker, we can get accelerated results and get people back, playing or back doing whatever they want to be able to do a bit quicker than traditional methods, I think. So next week, a bit similar to module 9, we're going to do module 10, which is very, very similar in the fact that it's going to be applying the upper limb module, so module 3, to specific cases. And I think the big thing here is like post-op shoulders, post-op elbows. People have had scopes, or they've had, rotator cuff repairs and stuff like that. And I think you see a lot of people that come into the clinic, maybe who've had a rotator cuff repair, and they don't really understand kind of why it's happened in the first place and what they need to do rehab-wise for that. So I think module 10 is really, really important for being able to take these surgical cases through the system, and also being able to kind of follow a surgeon's protocol, but still making good progressions at the same time. And I think, you'll probably relate if you do treat a lot of post-surgery patients, a lot of times you get some consultants who, best intentions, they're very cautious with the protocols. We might have 6 weeks non-loading, and the real question is, what do I do then if I can't load them up for the 6 weeks? What am I supposed to do with physio? But there is a lot of stuff that we can do while still appreciating that surgeon's and respecting that surgeon's protocol. So that's up next week. So we'll see you then.